Well, welcome. Tonight we're going to address an issue that is probably one of the most serious that we never talk about. And they'll get mad at me, but I'm going to call it physicians are people too. And we're going to deal with the fact that physicians really do want to enjoy their families and really do have a lot of pressure. And how the Milford Medical Center, we've always been proud of what's been built here, but one of the reasons we tend to keep our physicians as long as we do is that the board, the management, and the physicians themselves are so far thinking. So we're trying to get, as a community, ahead of an issue that, for lack of a better term, is called physician burnout. And we have three people here working extremely hard, not only to take care of us. You've heard me mention the Taj Hopkins many a time, the new ER center, but also making sure that it's staffed with the right kind of people and people who really want to stay in Milford. So let's start with introductions.
Yeah, hi, Al. My name is Kate Burke. I am an emergency physician here at Milford Regional, and I have practiced at our medical center since 1986.
And I'm Mark Skiba. I'm what's known as a hospitalist, which means I practice primarily in the hospital. I've been working at Milford Hospital for about 15 years. Prior to that, I was a primary care physician in the Milford Regional Physician Group.
A newbie, only 15 years.
Only 15 years.
And I'm Jeff Hopkins. I'm also an emergency room physician. I've been at Milford about 15 years as well. And I currently serve as the vice chair of the board of trustees for the hospital.
And Mark, you also have another role.
I was president of the medical staff for 6 years. I was on the medical executive committee for around 11 years prior to that. And Jeff and I share a role where we're on the wellness committee, as well as Liz Scirocco, who's part of that committee.
Now, I love the topic wellness committee, because we keep hearing in the med center, it's the burnout committee. And that's why I always joke saying, was it for burnouts? And it's like, no, we're trying to make sure people don't. Liz, what's the real issue that people are facing today in the medical profession?
I think, Al, what we've seen over the past number of years is that physicians are experiencing something called burnout, which is characterized by, I guess, an acronym I call ICE, which is clinicians become inefficient with their work. They become cynical about whether or not what they're doing really has any value. And they develop emotional exhaustion. And this is a phenomena that has become more obvious over the past number of years, with probably the main reason being the intrusion of a significant amount of administrative tasks that's really different compared to, for example, when I graduated from medical school back in 1983, where there is a significant amount of paperwork, insurance work, time taken away from patient care, interacting with patients, caring for them, making diagnoses, working with them one-on-one. Instead of working with our patients, which is what we're trained to do and doing procedures, instead we are now working with our computers and participating in the electronic medical record. The electronic medical record has been a very important advancement, but it has also turned many physicians into essentially data entry clinicians. So you have these highly skilled professionals that have trained for 4 years of medical school and anywhere between 3 years and 8 years of residency that are now spending more time doing paperwork and entering information into the electronic medical record than they are spending with their patients. And because most physicians went into medicine so that they could primarily interact with their patients and take care of them and make their diagnoses, they are now interacting with paperwork in their computer. And this has led to the burnout of those physicians.
Now, as we talk to pre-meds, up at Holy Cross, I've been very clear saying if you have a passion for medicine, for all means, go for it. But if you're doing it because you're going to have an easy life and make a ton of money, those days seem to have gone away. I mean, in Milford, you could take any Milfordian and name the 4 physicians that brought you into the world and threaten to take you out if you didn't behave. You know, it's a Cicchetti, it's a Mastriani. You go through the 4 and everybody was brought in by one of them. And you went to them, and if you weren't listening, you got scolded. But, you know, we never had a hospitalist. Never understood what that was. But now, it's got to be a killer to take you away, you know, what is it, 10.3 minutes per patient? I mean, how does that affect people?
Yeah, I think, you know, Kate made a good point. I think I think what docs went into medicine for certainly was not for money. We went into medicine because we really, probably because we excelled at science and more so than math and some of the other subjects. We certainly didn't excel in finance. But I think we want to help people. I mean, you know, it sounds cliche, but that's what we all did. We went in because we really enjoy helping people. We want to get back to being doctors. Doctors want to be at the bedside. The best thing that we can do when we care for a patient is we can be at your bedside, we can listen to you, we can treat you, we can put together a management plan, we can connect with our patients. When we have too many hoops to jump through, too many buttons to click, it takes away from the time that your doctor gets to spend with the patient. That's the quality time. So when that gets pulled away, it sort of, you wonder as a physician, you know, why am I jumping through these hoops? Why am I calling an insurance company to get pre-authorization for a test? Why am I having to click a certain number of boxes just so that the coding goes through the exact way it's supposed to go through? Physicians should not be worried about those things. They should be worried about the patient that's next to them, allowing that connection and that compassion to happen. And that's really the best time served, and that's what we want to get back to. And as we talk about burnout, I think, you know, that's what's led to a lot of burnout. But I think the way that we've kind of crafted how we're trying to look at it is, how do we promote wellness? How do we get back to being the doctor at the bedside? And that's the committee that we've focused on and the data that we've tried to measure.
But now you've got an MD or a MUDFUD, an MD PhD, who's now spent even countless more years in school training. And you're calling a sociology major to discuss whether your idea for this patient is the right one? I'm confused.
Well, it's all managed healthcare. That's what it really boils down to, right? You know, they want to manage what's being utilized in the healthcare system, and so, you know, this has evolved through, you know, genesis of medicine, right? Used to be private practitioners. You can make the call, order the test, you know, pay for fee. Now they want more standardization. You know, so that's why they want you to run it by these people, right? But when it gets in the way, that's when it's the problem, you know? So if Jeff's taking care of someone in ED, you don't want to have him stopping that care to make a phone call, or my wife, who's a primary care physician, stopping to say, I know this person needs an MRI, they've been having the back pain, we tried the physical therapy, we tried the non-steroidals, they need an MRI. Well, no, you can't really do that till you jump through these hoops, X, Y, and Z. And that's where the frustration comes in, and that's where, let's say, some of the disenchantment of medicine, because you know your patient, you want to do the best for that patient, yet there are these roadblocks that were developed for managed healthcare, but you have to strike that balance.
You know, I can see a young internist, a young resident, coming in saying, I'm not quite sure, and going to Jeff or Kate, don't take this wrong, but you've been around a lot more years. Does this make sense, or is there anything in your experience that would give me a better avenue for treatment? That makes sense to me, but calling some young political science major saying, let me try and explain to you something that you've never trained for, you've never understood, and would you approve it for me? I'm missing something.
It's after the fact too. So a lot of times we'll make a decision what we think is in the best interest of the patient. The patient's not safe to go home. You come into the hospital, we say, you know, I think you really need to come in. This could be something cardiac, it could be neurological, it could be something really serious. We really need to watch you. After the fact, we can get pushback from insurance companies saying, well, that person never needed to come in the retrospectoscope. So saying, well, now that we know the answer, a day later, it turned out that it was indigestion. Well, you shouldn't be admitted for indigestion. And we say, we don't have the answer. We work in real time, prospectively. So when we're seeing the patients, we're using the experience that we've obtained, our medical knowledge, to make the best decision for the patient. And it's frustrating afterwards to have someone, a reviewer from an insurance company, say, that decision you made, you know, you may have thought it was the okay decision at the time, but now we look at it, now that we have the answer 24 hours later, or when they're reviewing it a month after that.
Yeah, I should have passed. Why did I run? Can't
Right.
you see how the defense moved?
Yeah.
Well, yeah, if I knew that ahead of time.
Right.
But you got to pick, the two of you have picked the worst case because you're in the ER. You have less time to make a decision than even a hospitalist does.
Well, in some ways, I think the beauty of what everyone decides to go into, bringing it back to the wellness piece, that's where you really, you realize, and it takes you have to kind of pull back the layers and sort of get out of your mindset of clicking those boxes and jumping through those hoops. But it's that type of work, when you show up and if you can just see patients and you can see how they do, you can make a smile, you can have a patient that thanks you on the way out the door, then you really get back to like, this is why I went into this. This is what I really love about this job. I'll give you one example that is a good reminder to me. Is I have a patient who about 13 years ago had a heart attack, died on the table in front of me. We resuscitated this gentleman. He ended up getting stented. He got life flighted out of our hospital, and he lived. He survived. He comes back every single year. He has come back every single year on the anniversary date with a box of chocolates and a handwritten note where he just says, ever since that day when you told me, please, I don't want you to ever smoke another cigarette again. I have not had another cigarette, and I'm just grateful to be here every day. And those are the type of things, it may sound a little corny, but that's, you know, you think of that and you say, that's why I went into medicine. I want to do that.
Well, you know, again, one of the things you came on when you talked about strokes, because I am a man, right? I can live through anything. And then you said, okay, 1 million brain cells every minute. How many do you want to give up? And I was like, oh. I asked my wife, I don't have that many to give up. But, you know, when you start going through it and you start understanding, I mean, this is just silly, some of the things we do to ourselves. And when you put it in perspective, wow. But again, in business, we have administrative assistants. Because if I'm dealing with the paperwork, I'm not talking to my customers. And somehow they believe that me interacting with the customers is pretty valuable and they pay me a decent wage. But I can get somebody to do all my administrative work. Why don't we do that in the medical field?
I'll jump on that one. I think that that's a great question, and I think it's an area where we have an opportunity for improvement. That because there is a body of work that needs to be done to quantify a patient's experience in the medical system, in their physician's office, one way that we can be helped is to have really an adequate number of nurses, an adequate number of
PAs or?
Physician assistants, nurse practitioners, medical assistants, to help with all of the work that needs to be done for the care of the patient and for making sure that all of the patient's needs are being cared for, mainly so that the physician can really just focus on the patient, working on the medical decision making to determine what is the diagnosis and what do we need to do, and also establishing that trustful relationship so that the patient understands that they are our number one focus. And part of that, and part of the solution, at least one of the solutions we've found at the medical center, is the helpfulness of a person called a scribe, a medical scribe. So when some of us, and Jeff is included, and myself, I don't think Mark uses a scribe,
No.
but we have found that having an assistant that comes into a patient encounter with us, who is there recording the patient's history exactly as the patient explains to us what is going on, and also recording what the patient's physical exam is that we are describing to the patient and is being recorded into the medical record. And then when the medical decision making is done in terms of consultations to be made, testing to be ordered, reevaluations, and the condition of the patient are all entered into the medical record, so that we're able to sit with the
See
patient.
another patient or spend a few
Yeah,
minutes?
or spend a few minutes actually where you can have eye contact with the patient and exactly get a sense from them, not only from their words, but from their facial expression, talking to their family about what is going on. And in the meantime, the medical record is getting completed so that we can then look at the data. We can make consultative phone calls. We may look up a medication dose. We may move on and have the opportunity to see another patient, so that the actual productivity of the physician is taken with seeing an additional patient versus working on additional paperwork. Because one thing we found with, especially working in an emergency department, is you will see a large number of patients. And to complete all of your charting in a timely fashion is almost impossible. So then what happens is you have a significant amount of time you need to take at the end of your shift, or sometimes when you actually go home. And this is another major contributor to burnout. And in medical systems, they actually measure something called pajama time, is what this is called, where instead of a physician spending time with their children, going over homework, visiting with their spouse, relaxing, reading, recharging their batteries, instead they're still doing data entry. And that's another major source of burnout for the clinician.
Well, it's got to be incredible. I mean, Liz was mentioning that she has 2-3 hours a day.
Right.
Wait a minute now. 8-hour days? Seem impossible.
Yeah, I mean, a lot of, let's say, primary care doctors or even hospitals go part-time. But what does that mean in a medical career? I mean, usually an average work week, if you're a full-time doctor, it usually means you put in 60 hours a week on average. So going part-time brings you down to 40 hours a week. You know, when we go on vacations, we have to make sure there's Wi-Fi so my wife can, call up labs, and so she's not inundated when she comes back. So that's the thing. It's just the amount of time we put in documenting rose exponentially over the last couple of years, and that it definitely takes away the joy factor of medicine, because we didn't go into this to be dictationists or secretaries, or we went into this to practice the art of
But
medicine.
now, why, if I'm sitting there and I'm Ed or Phil and I'm trying to get the most out of my physicians, I want them to have a happy life and stay around. But productivity-wise, it would seem this idea of a scribe, you should have one attached to you every minute of the day.
Right.
Why does that not work?
I honestly believe that they are looking seriously at this as a solution to address some of this burnout issue. If you can touch a couple of the points that are particularly difficult for a clinician in terms of what is contributing to their dissatisfaction in that work environment, that is a real win. So part of the wellness committee that has been assembled is to look at what would be viable opportunities that could be implemented that would be very useful, and to measure the effectiveness of those. And I think that scribes are clearly on that list.
I'll give you another example of something that brings a lot of positivity and brings value to a lot of people is teaching. So Scribes is an excellent example of something that is value added, where we can spend more time with patients. There's an education component that a lot of our partners really enjoy teaching medical students, residents. Now we are preceptors for a PA program, and that teaching component, that's kind of how we all were taught. You know, we had our mentors when we were in medical school and residency who kind of showed us the ropes. We're able to do that with some of the students and the residents coming up, and a lot of us find a lot of joy with that. So things like that, to be able to have some protected time. So outside of your 60 hours a week, if you can carve out 10 of those hours to have as educational time, that's another thing that, when you leave, you can feel, hey, I really enjoyed meeting with the residents.
I can see them growing.
Yeah, they keep you on your toes as well.
Because the studies show, 20%? If you do 20% of what you have joy in, then you can put up with 80% of the other stuff. And those studies have been done mostly in business, but I think it applies universally.
It worries me because I remember way back when they were talking about residents working 80-hour shifts. It scared the living heck out of me. Not that anybody in Milford would be under, a quality bar, but Kate, with all due respect, I'd rather have the Kate at 1 hour than the Kate at hour 79. And it seemed like we had to address the fact that you couldn't run physicians, because physicians are people too, 80 hours and expect them to be at their peak.
I think you bring up another good point. I think the whole notion of physically exhausting practitioners due to having a single practitioner practicing a huge volume of work creates a real problem. And what's interesting, and this has been shown in the literature, that one of the contributors to also clinical burnout has been with our aging population that we're experiencing an age wave, that the complexity of patients that we see routinely, and I know both Jeff and Mark can speak to this, but say 30 years ago when I started my career in emergency medicine, on evaluating a patient, you may have, and I'm just using this as an example, you may have had 10 data points you were analyzing. Whereas now, because we have an older, sicker population routinely coming to the emergency department, for example, because other folks with less severe problems are going to the primary care or to an urgent care center. Now, for example, patients that we see, they may have 80 data points per patient, more complex. In that same patient, when we're admitting the patient to Mark, again, historically, not as many data points. Patients were nowhere near as ill or didn't have as many
complications.
Chronic complications.
Medication listed.
So that the amount of resources needed to care for and manage the same, quote, number of patients is more, even though your number of patients that you're actually managing may not be higher, but the complexity of each patient then is more. So that you definitely need more resources, more one-on-one nursing sometimes, more transporters, more help with an individual patient. And in the emergency department, and the same thing goes in the house. And when a clinician doesn't have that additional help to manage the more complex patient, it makes caring for your patients during that period of time much more difficult, much more challenging, because part of what's going on with us is an emotional investment in our patients, but we also have decision making that can be life or death. So you need to have the mental space to be analyzing all those data points and not be pressured to have to move on to your next case. So more resources are needed to manage this population of patients.
You also bring up a point. Mark opens up a chart or looks in history. What young Jeff Hopkins did 15 years ago is now a data point of the 80. Boy, I want you to be fresh when you're filling out my medical record. Not that you would put anything wrong, but let's face it, 60-hour Jeff may not catch every nuance that 2-hour Jeff could. So, it kind of seems obvious to me that I want every ounce of those neurons thinking about, every neuron firing, thinking about important things, not do I check box 32? Oh, to get this through Harvard Pilgrim, I have to have 32 plus 14 plus 18. And candidly, some of these young kids are better at it than we are.
We used to wear it almost as a badge of honor. During your training, you do your trauma month. And you were 24 on, 24 off. And you did that for the whole month. But you weren't really 24 on, because you were 24 on, but then you had a 2-hour sign-out period where you rounded on patients. So you're really 26 on, 22 off. And we practiced probably in a way that wasn't great for patients, but we kind of said, this is the way to do it, this is the way my predecessors have done it. I think this focus that the medical community is now acknowledging, there is a physician burnout issue and we need to focus on physician wellness. I think that the timing is right, and I think our newer grads, fortunately, we're seeing some work hour restrictions. We're seeing some good changes that can prevent some of those medical errors, sort of the lapses in judgment. You'd think almost along the lines of an airline pilot. They don't allow them to fly over.
I don't want you to be up 26 hours and wheeling a scalpel over me.
Right.
Sorry, I'm not qualified to say whether you're at your peak, but you still are a human. If you've been up 26 hours, I want the 2-hour version, not the 26-hour version.
But I think, definitely there's a change of attitude, because before, like you said, you used to wear it as a badge of honor. And if you failed to achieve that, you looked upon as weak, or you're burnt out. We're looking at the system now. The system is creating this burnout. And people are acknowledging that no one can withstand this for a long period of time. We have to work on what's causing this burnout. Instead of it being you, the physician, who are weak and can't handle this, it's more like, why is the system grinding down good people? We just want good doctors to take care of patients and provide good care. And under the system we have, it's making that more difficult. So we have to look at the system and what can we change. I always feel doctor's only as good as the nurse. The nurse is only as good as what she has for support, and so it is a team effort, and so we have to look at the big picture, and that's where we're at now. And I think Jeff brings up a good point. We're finally at that point where we're looking at the system and not at burnout has negative connotations. Oh, you can't handle it, you're burnt out. That's why we're looking at the wellness of the physician and what's causing them to be unwell, and if they're unwell, how do you expect them to make you, the patient, well?
And you start thinking about it. I mean, this is horribly sexist, so I'll apologize, but it seems like the women that are physicians, the young physicians, get double whacked. And I'll admit it, I had life of Riley. I had 2 daughters, and I got all the fun times. And my darling bride, full-time job. But when things went wrong, they went to mom. I can't imagine it's any different for a physician, just that you have less hours and more stress. If I make a mistake, today, I made a decision about a client. If I blew it, I maybe blew 50, 100 grand. Not that that's trivial, but maybe I can go fix it tomorrow. You all make a mistake. There may be no tomorrow, and you're not talking about money. So the pressure, a layman, I can't imagine I could really understand what you're going through in an ER.
But you bring up a good point. The expectations are a little bit different in the medical field versus business. We're supposed to be infallible.
You're dealing with my child's life. Yes.
And we ourselves, we take an oath not to do harm and to do the best we can. And so that adds to the extra additional. I think everyone feels burnout no matter what they do, but there's these extra things that have tipping points when you look at the medical profession.
Now, Kate, as a female physician, is it real what we read, that there's extra pressure on young female MDs?
Yeah, I'll have to say that when you look at the data, the highest burnout in physicians stratified by age, gender, and specialty is in women under the age of 45.
Now that's the data I saw. Is that the reality?
That's the reality. And then over the age of 45, when you stratify for age, gender, and specialty, it evens out. Then both men and women have the same level of burnout in the field.
Why?
Well, when you think about it, just from a factual point of view, that women physicians generally want to have a family, and no matter what, and no matter how you slice it, typically they're the individual that is having the baby. They are pregnant. They're the ones that are with the baby.
But with all due respect, that's a few months. It's the rest of the life that my darling bride still carried a much heavier load.
Right.
9 months you can deal with anything.
Right. Well, usually by the time a clinician is 45, unless they decided to have children late in their career, usually some of the childcare issues have changed. And there are, though, now studies emerging, especially with men who are physicians who, under the age of 45, became much more involved in child rearing, exhibit some of the same numbers of burnout that women have exhibited.
I don't want to minimize the pregnancy, but that's 9 months.
Right.
I think of the 18 years.
Sure.
And no matter what I tried, I know that the burden was heavier on my darling bride than it ever was on me.
And I think also what you'll see is that not only women, but men will try to adjust their schedules for raising families. In 2018, it is very clear that young physicians, they do want to have a better work-life balance, and raising your family and seeing your children grow up, you're only going to have a 2-year-old once, that this is very important to them.
But now, you see the trend that physicians, brand new physicians coming in negotiating their contract, are no longer trying to milk every dollar. They're becoming more, I guess, balanced, saying, I'll trade off some income, but I want to be able to see my family. Is that an impression, or is that reality that they negotiate hours?
I think it's reality, and I think that's what we need to offer to keep these people around. But then the problem becomes the patients are still there. They still need to be seen. So as you negotiate more free time, who's taking care of the patients?
Jeff sent the memo. You can only get sick between the hours of 8 and 5.
That's enough.
Yeah, right.
But that's where physician extenders are coming in, physician's assistants, nurse practitioners to help fill that void. Just for that very reason, because the number of physicians, people are living longer, so we have more patients. They're more complicated. So you have a patient population that's expanding and expanding, and you have a physician population that's shrinking and shrinking, because they're doing just that. They're valuing their family life. They want more free time, and we should be offering that. We should offer that flexibility. If you have young kids and they have the summer off, pare back on your schedule during the summer. Offer that to your young physicians, then you ramp up when they're back in school. You have to, that's the flexibility you need to preserve wellness in physicians and to preserve, I think, the career as a whole.
But that sounds great. But now, when you get back to Kate's 10.2 minutes per patient, how do you make that happen in reality?
You review the chart before you go into the room. You're very focused when you're interacting with the patient, and and the thing is, in sort of making the patient feel slighted, you sit down when you interview the patient. So you make eye contact with the patient. I went into science because I wanted to teach. I find that is a great opportunity. I have a great pupil. I'm in there. I'm telling the patient about their illness. They're telling me about their symptoms. It's a great exchange. You can do a lot in 10 minutes if you're prepared when you walk in. Just review the chart, look at the labs, so that when you're telling them this is what's going on with you and this will be the plan, they feel as though, oh, this guy knows what he's doing. I have trust in them. He's looking me in the eye. He's asking me questions. You can get a lot done in that period of time. We've all had to learn, and that's when you become an older physician or more experienced, how to be laser focused. When you're young, you're rambling, and it takes a while to learn that. But as you get more seasoned, you get more focused. And
I'm always amazed. And I'll be personal, my mother. She went in for her routine and they called me and said, she has intestinal cancer. We can wait 2 days to or we can move, but we know. Okay? 10 years later, she's still saying, I'm going to go see Mona. It wasn't Dr. Kadis. It wasn't my oncologist.
Right.
But the fact that she's been seeing the same person for 10 years, I mean, the compliance was higher because, you know, if Dr. Mona told me to do this, I have to do it. But it was just the familiarity. Her blood pressure wasn't spiking because she's going to man's greatest hospital in town.
Mm-hmm.
You know, she's just going to her little hospital, even though it's no longer a little hospital. And she's seeing her oncologist, which she never understood. Just, that's Dr. Mona. She takes care of me.
That's the importance of preserving the community of physicians that we have. We not only want to recruit, but we want to retain physicians. We want physicians to be in our system that are going to be there for years. So like you said, you can have this relationship that builds over time, this trust that builds over time, where physicians really know their patients. The only way to do that is to prevent physicians from getting burnt out and leaving the practice early or cutting back their hours. So the system needs to change in order to make that happen. And another thing would be sort of on-call docs. And fortunately, you know, like we don't necessarily have we're not on call per se. We come in, we do our shift, and we work. But a lot of docs, they have a full day of patients, a full OR schedule. They go home, and then they're on call that night. And then when we call from the emergency department, you know, we may get a physician who is less than excited to hear from Kate or myself or from Mark, given the consult in the middle of the night. But to have another layer of support, so advanced practice providers, physician assistants, and nurse practitioners, an extra layer of support to have in the hospital to help manage patients, so that surgeon who operated all day, who's now on call, if they need to come into the hospital and operate and there's an emergency, they can take care of that. But if it's, we need an order for Tylenol or some IV fluids, we can have a whole group of advanced practice providers help manage that patient and let the surgeon sleep,
Well,
so
the
he
poor
can
guy
be
or
fresh the next
gal
morning.
is scheduled to see their 3-year-old or 4-year-old. Let's see, Wednesday at 6 to 8 o'clock, I get to see my child. I've been on for 3 days. And then all of a sudden Jeff calls. It's like, "Rrr." You know, I scheduled. It's in my calendar. I get to play with my daughter for these 3 hours. I mean, it's got to take a toll on you that, one, you have to schedule. You know, I mean, I was terrible. I just made it a point to say, when it was this time, I'm going to be home with my kids, and I'm going to enjoy. And anybody from the office knew after 9 o'clock or 8:30, call me all you want, because it's just my darling bride and I watching TV or relaxing.
Yeah.
But
It's
again,
almost that way there's too much access to information. I know Kate and I have suffered from this, and Mark, you probably do too, but with electronic medical records, you can always log in to see what's going on in the emergency department. You can always log in and kind of double check on things. There's almost too much information that we always have access to, and it's almost like, you know, the old rotary phone versus the iPhone. Constant influx of information all the time. When in the past, you'd really have to go out of your way. You'd have to dial that number and call someone to get the
you'd have to
information.
drive to the center.
Yeah.
Now,
So it's important to have a time, like you said, turn that off.
Right, that's actually, that is listed as another one of the why now questions, because I think one thing to think about when you do think about physician burnout, and why now? Why has this developed? Well, think about your cell phone. Think about your computer. How often do you look at your cell phone? How often do you look at your computer? So that's where lots of high-value information is shared. Also, access, phones, texting. All kinds of people phoning and texting with lots of information available 24/7. And this constantly on phenomenon it wears people's brains out. And people need to refresh. You have to be able to get away from your body of work, your profession, so that you can be renewed. You can sleep soundly, you can get up again, you're refreshed, your brain has recovered with good sleep, and then you can begin your work again. So this whole culture and environment of constantly being on is another major contributor. And so part of the solution is deciding and working with one another and saying, okay, if you're not on call and you're not administratively on call, you really have to just shut the PC,
And again,
turn the phone
I'm
off.
going on vacation next month. I'm taking a whole week. And my family, I am blessed that they understand. If they want me to be totally relaxed, I get up at 5:30. They, on vacation, they barely get up at 9. So I've got 2.5, 3 hours to catch up on my computer, catch up on all my work. And then I can say, okay, anything that I need to deal with can wait till 4 o'clock today where I'll take another hour. But it gives me the whole day to relax.
Right, exactly.
But y'all don't get that because nobody reads Jeff's memo that, okay, it's 8 to 5. I'm not supposed to be sick outside those hours.
Well, I mean, that's where it's kind of a deal with the devil, in the sense that you have multiple providers because your patient will get sick any hour of the day, and so that's why a hospitalist was created. Before I was a hospitalist, I was a primary care doctor. I had to get up at 4 a.m., round in the hospital, see my patients, go to the office, field calls from the ED regarding new admissions. After I saw my whole panel of patients, go to the hospital, discharge patients I had to discharge, admit more patients. Then if I was lucky and be on call that night, might hear from more patients during the course of the night. But in order to give a sane life to primary care physicians, a hospital. So I am the doctor you see in the hospital instead of your primary care doctor coming in. But with that, you have to have an electronic record so you have proper handoff, because that's the big thing. Are we properly, when Kate or Jeff gives me a patient to the hospitalist, they give me a handoff. Then when I leave at 7 o'clock, I'm a nocturnist, by the way, even a more bizarre title. I only work at night. But I have to give sign out to my peers in the morning, so when they pick up the care, they have proper sign outs so they can care for them. So that's the thing. I mean, electronic, we poo-poo electronic medical records, and that really adds to a lot of hardship to my life. But it's necessary because multiple providers now are providing for care for our patients to give us that free time.
I remember when my darling bride was pregnant with my ungrateful offspring number 2. I warned Dr. Bellucci. I said, my wife has no patience. The first child, she was in labor for almost 2 hours, 2.5. Now, I have it on good terms that number 1 left breadcrumbs, so number 2 is going to come real quick. So the minute we call, please take it serious. And sure enough, Mitch showed up. He actually, poor guy, it was midnight when we checked in, and he went to sleep in the bed in the next room. Because 45 minutes later, bang. But you think about it, for him, we totally disrupted a night that I would imagine he was looking forward to sleeping in his own bed with his own wife, with his own kids in the house. And here he is at midnight being called and having to rush to the hospital. So I would think the hospitalists have to help also that demand of, Jeff, we need you right now. Kate, show up.
Yeah, it's an impossible job for people to work all day long and then have that, and then admit patients all night long. It disrupts your sleep cycle, it leads to burnout, leads to, a bunch of different problems. So I think the hospitalist program has been a fantastic addition. It actually allows, that's probably one of the first things that we did to address burnout before we were calling it burnout, was to allow the primary care doctors to have their office hours and then to have admissions afterwards go to a hospitalist service. So I think that was sort of one of the first moves in the right direction. I think we just have a long ways to go. And there's a lot of good ideas out there. There's a lot of best practices. There's, we had mentioned scribes, more teaching time, setting aside time for things that you really like. I think we just need to try and implement as many of those as possible under the financial constraints that we have under the current healthcare system, where financial pressure is doing this, productivity pressure is doing this. So you got to find sort of some happy medium in between.
And I think what's important to understand is that our administration and our board and our medical staff, they understand that there's a very tight connection between physician burnout and wellness and patient safety, and that this is a number one priority for all of us to work together as a team to look at all the opportunities we have from an organizational point of view, from a workplace, and when I say workplace, I mean out in the community, our colleagues with MRPG, and certainly in various departments in the hospital, and then individually, and look for those opportunities that can be implemented with our colleagues in a reasonable fashion, in a cost-effective fashion, things that can be done, recognizing the importance of this. And I also believe that this focus is important because when we're recruiting new physicians to come into our system, we want to explain to them that our administration is working really hard to be sure we have enough and adequate staff to be assisting us to care for our patients, so that is not one of the obstacles we have for delivering great care to our patients. And I think I know I personally am very grateful that our colleagues, our administration, and our board are very focused on this because in my view, this is the single issue that we have to address as a system to really get right so that we can have the safest possible and best possible place for our patients to come.
So now I'll put you on the spot. Phil, turn off the TV. Ed, don't listen. How does our management board compare in your mind to other regional centers?
I think the fact that our board and our administration actually spent money and went to the AMA to measure the level of burnout amongst our medical staff, where they determined that we were about the average burnout level in the country, which is half of your doctors are burnt out and half are not, was huge because, as you know, as a scientist, that if you don't measure something, you can't change it.
If I don't know the baseline, how do
Right.
I...
Right, exactly.
Right, so that any medical center worth their weight today in this healthcare environment, number one, needs to understand how clinician burnout is directly related to patient safety, and that the way that you address it is first you measure it, and then you organize your team, and you figure out what you can do to make things better.
Okay, if I'm worried that I have a certain affliction, I have a clinical, I draw blood, I collect urine, I run an ELISA, and I got a point that says above this level, I got a problem, below, no problem. I go to a physician. I can't administer a diagnostic test that says 3.2, oh, you're burnt out. 2.4, you're not. How do you really judge? Because you're going to get the physicians who, most of them, or the vast majority, especially in Milford, love serving their patients.
The survey we did, actually, speaking of the board sort of taking this seriously, we made presentations to the board, and I think they really understand that this is like Kate said, a hot button issue that needs to be addressed. Invested in us going out and finding what is the best tools to use to measure burnout or wellness. And we went out to the American Medical Association. They have some validated tools that we use to survey. They came in, we sent out a survey, about 30% of our physicians and providers filled out the survey. So we did have a good sample size, and we have validated questions that can kind of give us our baseline.
But give us an idea. What would you ask? If I go up to you and say, Kate, are you burnt out? Well, no.
Right. Well, I think some of the common types of behaviors that you may witness would be, for example, clinicians who, they lose their joy of practice. You may go in and you may just feel like, gee, Kate's just much more monotone than usual. She just does not seem to be as engaged with me. something just doesn't really seem to be right. You know, I hope she's okay. And patients are very smart, and they'll pick up on that. In the clinical environment, where when you may be just wanting to discuss a case with one of your colleagues, they just may not be as interested. And you get a sense that, gee, you know, are they having a bad day, or is this a pattern that I should be concerned about? When you have a clinician who comes to you and says, you know, I think I'm going to go half-time. I really just can't do this anymore. It seems to be too much. My spouse says that I'm kind of always angry, and my kids think that too. So that's how you hear about it. You know, some of the more profound problems with burnout with physicians can be broken relationships. You know, someone can have a divorce, someone can have a substance abuse problem or an alcohol problem. And frankly, one of the most scary and prevalent problems is suicide in physicians, which is approximately 400 physicians commit suicide each year in the United States. It's basically an entire medical school class is committing suicide every single year.
Now, is that why you see so many physicians marrying other MDs? Because they're the only ones that can understand what the life is?
Well, yeah, well, I was going to say, I married my wife and met her through residency. You know, it's just, I don't know if it's that or, yes, there's a level of understanding, or a lot of nurses, not of doctors marry nurses because they understand the field. I don't know. I don't know how to dissect that, you know, with regard to how they choose a partner. Or it's that you're going and going, you're very goal-oriented, you're just like going through your program, you're trying to get your career started, you're finishing residency, it's like, oh, time for a family. You know, it's one of those things too. I mean, because you're, you know,
I forgot to check off that box.
Yeah,
Time for family.
Oh yeah, reproduce. I forgot. So you know, there's so many factors that play into that. But I think also, as you already alluded to, a person that can understand, you know, what you're going through is helpful with regard to all the pressures that.
Well, I remember when I got the call from my darling bride saying, "You're leaving Sunday?" I said, "Yeah." "You realize it's Father's Day?" And I'm like, "Oh. Thank God it wasn't Mother's Day. I'd be really in trouble." I said, "Oh." She goes, "Okay, we'll just have to get the family together for brunch instead of dinner." But, you know, she understands because she's got the same pressures in the business world. So, you know, I always wonder, I mean, number one, marrying another MD must exacerbate the problem because you're both pulled 9 ways to Sunday. But at least you both understand that when it's 9 at night and you get the phone call and you're supposed to be tucking your child into bed, that there's no really a choice.
I think we owe such a debt of gratitude to our spouses, to our parents, to our friends, to our coworkers who put up with us. For all the times you come home and you're just spent. And we probably don't say thank you enough. So if nothing else, I'd like to say that on this show to my partners who always have my back, my colleagues who are always there helping me out, and mostly to like your family and your friends who always kind of support you. We probably don't express that as much as we should, but they're the ones
No,
who
because you're too
put up with
tired.
us.
When you get home, you just want to crash.
Yeah, right.
When you think about how understanding your family is, so let's celebrate Christmas the day after, or we'll have Thanksgiving this week instead of, you know, this because of your call schedule, and how many sacrifices they make to work around your schedule. And that's huge, and you're right, they make such sacrifices.
Well, you know, I remember when we were living in Paris, we were expats, and we'd be traveling 70% of the time. And, you know, a friend of my darling bride would say, "Let's get together. Let's see, in 2 months we'll be in Istanbul. Can we meet there, or do you want to meet in Athens?" And you're sitting there saying, what am I doing? You know, I can't schedule a weekend. I got to wait 2 months for us to, you know, our schedules will both be in the Middle East, and we can meet. And then you just say, thank you for tolerating me in this life I've brought you into. At least you're both MDs, okay. You both decided to get in. You can blame each other.
Exactly. We begged to go to medical school.
So what's the next step with the Wellness Committee?
Good question. I think what we alluded to before is identifying best practices. And then I think what the AMA had recommended. Number one, you get your baseline data. Number two, after you get that, you go back and you have focus groups. And you look at some of the groups that scored really well, some of the groups that didn't score as well. And you can you really need to drill down on all different areas and find out what's working, what isn't. Are there things like scribes? Is that something that you can implement in other departments? Teaching, whatever the
tying
area
yourself to
is.
UMass Medical so you get some med students that you can take joy in helping them.
Yeah, exactly.
Or altering incentives, looking at quality instead of sheer number of people you see. There's many things, many approaches. An article that Kate brought to our attention, a Shannon Felt article, he's leading the way in physician burnout. There's a 9-step approach you can take to implementing these changes to improve physician well-being in an institution.
The physicians only get 9-step and the addicts get 12. You're getting shortchanged again.
We have leadership in our hospital that's focused on this. So in terms of things like one of the things that came up in the survey was we don't have enough time to hang out outside of I'm seeing this patient, Mark, I'm giving you this patient, and it's all business, business, business. But we said, what about just being able to learn about someone's family, have that extra time. So trying to do social events. One thing that we recently started at the hospital were grand rounds. And that's a great way for people to kind of come together, and you see the doc who's in the primary care office all day, and they see me who's stuck in the emergency department all day. You finally have sort of an area where everyone can kind of come together and get to know each other a little bit better. That's another lost subject because everyone is so, you're at the assembly line getting through as many patients as you can, and being able to actually get down and get together with colleagues and learn about your friends, learn about the people who are going through the same things. It's therapeutic.
And isn't it ironic that we've just run out of time? As you talk about not having enough time, again, amazing what our medical community has grown up from the little red building, the little hospital that tried and could, to a world-class medical center. Now it's time that we take a few moments and think about the wellness of the people who take such good care of us. So we thank you for taking care of our MDs and our nurses and everybody else. And as always, to the 6 loyal viewers we have, may God bless. May tomorrow be a healthier day than today. Thanks for joining. Just have to wait.
Not too long since I've been home.